The American Brain Tumor Association is pleased to welcome you back to our webinar series. Our webinar topic today is Skull-Base Tumors 101. My name is Ambreen Mann, Program Manager here at the ABTA, and I'm delighted to introduce our speaker. Dr. Gabriel Zada is a board-certified neurosurgeon and internationally recognized expert in brain, skull-base, and pituitary tumor surgery, as well as a variety of endoscopic and minimally invasive neurosurgical techniques. Dr. Zada has treated over 2,000 patients with brain and skull-based tumors using both minimally invasive and open cranial approaches. As director of the USC Brain Tumor Center, Dr. Zada directs a comprehensive, minimally invasive cranial surgery program, including endoscopic skull-base and pituitary surgery, exoscopic minimally invasive parafascicular surgery, and interventricular neuroendoscopy. Thank you so much for joining us, Dr. Zada. You may now begin your presentation.
Great. Good afternoon, everybody. Ambreen, thank you so much for the wonderful introduction. I'd like to thank the ABTA for the opportunity to share some thoughts regarding management strategies for skull-based tumors. So let's dive into this, and feel free to put any questions in the Q&A box, as Ambreen mentioned. So today we're going to talk about a subtype of brain tumors, which are collectively known as skull-based tumors. And you may be wondering, why do we categorize these differently? What do they have in common that they deserve or merit their own category? Well, the skull base, as you can figure out from the name, is the base of the skull, where anything below that is no longer considered the brain, essentially. It's a very intricate and complex area of the brain, which is why it can be challenging to have tumors in this area. The skull base is, by definition, bone in many areas. And to get to these tumors, historically, we would have to do very big operations and retract the brain to get down to the base of the skull. That means that for a surgeon, it's a deep location, and you're often surrounded by a very important anatomy, which is the other factor that makes tumors of the skull base so challenging, is that they are very intricately associated with the cranial nerves and blood vessels. So arteries and veins that are very important for brain and neurological function, which I will talk about. And the other challenging factor is that they can be invasive tumors. And you're going to hear that word come up a lot, invasion or invasiveness. And I'll explain why that's such an important differentiator as well. So this is just another view on a CT scan of the brain and skull. And so the forehead's over here and the back of the head is here. And so the skull base is this area along this entire bottom here, going from essentially the forehead, and we would call this part the anterior skull base, anterior meaning more frontally located, back to the middle skull base, which is around here. And then over here, we would say the posterior, or as I'll share with you, the lateral skull base and what that means. So I always like to start with a case. I think it really brings it home. This is a young gentleman who I treated a couple years ago, who was in high school at the time, and he was all set to play basketball as a point guard, but then presented with double vision and was found to have this tumor here. This is a tumor of the middle skull base called a clival chordoma. It arises from this area of bone called the clivus. And as you can see, it's located really in the center of the entire cranium here, a very deep location, and it's pushing on a really important area of the brain called the brainstem, which subserves so many of our critical functions. It's surrounded by important nerves and vessels. So how do we treat something like this? Well, this is a textbook from just about 20 years ago by some very well-known masterful neurosurgeons. And I really like starting with this because they called approaches to this area of the skull base approaches to no man's land. And that's really where we were even a decade or 2 decades ago. There was no good way to get to tumors in this area. So how did neurosurgeons and skull-based surgeons used to do this? Well, they used to have to do a huge operation and retract the brain to get down to that deep area, or open the face up. You can imagine how morbid that is, to have a very large incision and open the face to get back to that area. Well, fortunately, we can reject some of those techniques now, and we have a variety of technology and surgery that enables us to treat skull-based tumors much more safely and effectively. So for a tumor in this area, we would now go through the nose using a camera and endoscope, or we call that an endonasal technique. And it takes us right back to this tumor without the need to open the cranium and do a large craniotomy or actually retract the brain, which can have neurological consequences. So this young man was able to graduate from high school just several weeks after the operation. He went on to have some radiation therapy, but here's his MRI several years later and was still in remission from this chordoma. So things are evolving very rapidly, fortunately, in this area of managing brain tumors. So I'm going to highlight, not just from a surgical perspective, but why that is the case. So let's talk a little about what comprises skull-based tumors. Well, if you look at skull-based tumors among all brain tumors or primary brain tumors, so excluding tumors that metastasize from other cancers, such as breast cancer or lung cancer, then skull-based tumor make up more than half of these tumors. In fact, more than 60% of primary tumors located within the cranium. So that's quite a bit. They tend to be benign, but they can be malignant. And one thing I'd like you to take home as a message is that benign versus malignant is not always as critical as you might think in this area, because even benign tumors can be invasive or can have significant consequences for a patient in terms of treatment and quality of life. So, so please remember that point as we move forward. The most common skull-based tumor we treat are meningiomas, so I'll be talking about that quite a bit. Pituitary tumors, craniopharyngiomas, schwannomas, chordomas, and chondrosarcomas are often grouped in one family. And then a variety of malignant tumors, which fortunately are less common along the skull base, but we do see metastases from other cancers from time to time. So we neurosurgeons who do skull-based surgery are comfortable treating really all of these conditions for the most part. So I'm going to take you through a general overview of how we approach skull-based tumors. So when we are referred a patient, they often come with an MRI showing a skull-based tumor. They may have symptoms, they may not. So the first thing we do is we'll obviously talk to the patient and examine them. But when we look at the MRI, we try to figure out what it is. We're often very good at telling what type of tumor it is just off the MRI and whether it's benign or malignant, most likely. The next question that enters my mind is this something that needs to be treated now? We see a lot of patients with skull-based tumors that are discovered incidentally. Someone may faint or have a car accident and undergo an MRI, and then we discover they have a tumor. So we look at their age, we look at whether they have symptoms, how it was discovered, and then really talking to the patient and seeing what their preferences are is critical. Quality of life is so important for any brain tumor, in particular skull-based tumors, something that we really focus on prolonging for as long as possible. The next question is there a medical treatment? Can we avoid surgery in this patient? There are some pituitary tumors, for instance, that can be treated very successfully with medications alone. So that's obviously, if you're diagnosed with one of those, you can consider yourself lucky vis-a-vis having another more complicated tumor that requires surgery or radiation. The next question is, can we treat them with radiosurgery effectively and avoid a major operation? Again, there are many factors that go into that, including age, tumor size, etc. If someone does need surgery, the next question I'll usually ask is, can we do the operation with a minimally invasive option? So we can really give them all of the benefits that minimally invasive surgery offers, which is usually a smaller incision, improved quality of life, faster healing time. But the goal is really to remove as much of these tumors as possible for the most part. Many benign skull-based tumors can be cured if the whole thing is removed. When we can't remove all of the tumor, it's usually because they're invasive or they are attached to nerves and arteries. And when that's the case, our goal is to remove as much as possible safely and then figure out another way to treat the remainder of the tumor that we will often leave behind for safety reasons. That might be, it might be a form of radiation or radiosurgery, might be a medication or chemotherapy. And those decisions are made best by a multidisciplinary tumor board, which of course many institutions have, and we meet weekly to make these decisions as a team. So here's an example of a meningioma, and what's important about this tumor is that it's very invasive. Now, this was initially a benign tumor, never really reached a formal cancer diagnosis, but for this patient, that doesn't matter as much. This person has had multiple operations, radiation, chemotherapy, and this is essentially an uncurable tumor, even though it's not a cancer because of tumor invasion. So fortunately, we're developing new techniques and treatments for these types of tumors, which I will talk about, but please keep that invasion aspect in mind. For meningiomas, important considerations are the size of the tumor and the degree of invasion, how much brain edema is around it, whether we think it's a soft or hard tumor, and how much we can predict whether it's hard or soft based on an MRI, what the goals of surgery are, its relationship to nerves and blood vessels, patient preferences, as I mentioned, and then getting good outcomes for cranial nerves. So the cranial nerves subserve different senses, such as vision, hearing, facial movement. There's a lot of them, and so all of these outcomes are very critical for skull-based tumors. Then we look at whether a patient has had a prior operation or radiation in the past. Now that's very important because the first operation for patients with skull-based tumors is usually the most important one. If a tumor is treated properly and removed the first time, that usually offers a much better long-term outcome. So some patients with skull-based tumors and meningiomas will require open surgery, which is a craniotomy. That's where a piece of bone is removed and we have to go in usually with a microscope to remove the tumor. And there are many types of craniotomies that are customized for each patient based on where the tumor is and the size and what type of tumor it is. So here's a young woman in her early 30s who had vision loss and a meningioma along the skull base. It was wrapped around her arteries here and pushing on her optic nerves, which are the nerves that allow you to see. So this is not a tumor that's treatable with a minimally invasive option, and she required a real craniotomy for this. I'll try throughout this lecture to indicate with red arrows the direction or approach which we have taken to treat a tumor, so you can understand in your mind's eye how we approach this. So you'll hear that word a lot, approach. The decisions we make to get to a tumor are very critical to enable us to treat it successfully and safely. So you can see how we approached this tumor. We were able to get the whole tumor out, and fortunately she recovered well, despite it being an invasive and complex tumor. Here's another example of a meningioma located along the skull base and causing vision loss. She was treated with a smaller craniotomy coming in just under her frontal lobe here to remove this one. And here's yet another example of a larger tumor along the skull base. And this patient also required an open craniotomy, but what's called a bifrontal craniotomy, which is an incision that's on both sides and removal of a piece of bone along the forehead to allow access to this larger and more complicated tumor, but nevertheless treated successfully. Just another example of a meningioma treated with a craniotomy. And then this one I put for a reason, often surgeons will have to make a decision of whether a tumor can be treated with an open approach or a minimally invasive or endonasal endoscopic approach. And when tumors are wrapped around nerves or blood vessels or invading the canals where these nerves go through, often that will require an open approach, as this woman did. We were able to resect most of this tumor, but because we couldn't remove everything along the nerve, she did have some radiation afterwards and is still doing very well to date with preserved vision and no tumor recurrence. I'm not going to show too many videos during this lecture. If you're squeamish about surgical videos, you may want to not look at this for just a couple minutes, but I do want to highlight a couple approaches that we can take and show you what these look like. This is a meningioma that was treatable through the nose with an endonasal approach. So I am going to show some surgical video here about how this looks. And hopefully there's really not a lot of blood, as you can see with these operations. So here we are removing the tumor from the optic nerves and chiasm here. And this is all done through the nose with the camera. So this is my ENT partner, Dr. Robel, and myself, and we work as a team to do these operations. We're able to remove the whole tumor and improve vision. And yet another example of a skull-based tumor in a young woman with the meningioma, and we were able to treat this again along the clivus with an approach through the nose to remove the tumor. So sometimes patients who need craniotomies, we can still do with minimally invasive approaches. So this was one of my patients who provided permission to use his picture here, and you'd be hard pressed to figure out where his surgery was performed through. You can tell that he and I have the same haircut, and we're both challenged follicularly. So a big scar on top of his head, when avoidable, we try not to do. And if you look very carefully at his right eyebrow, that's where his incision was. If you took a look at him on the street, you may not notice that, but we can use an eyebrow incision and craniotomy to get to a lot of tumors in the anterior or more frontal skull base. So here's just an example of a tumor that we treated with an eyebrow craniotomy and we're able to remove, and these usually heal very nicely. So let's talk a little about another common tumor type, which are pituitary tumors. And I treat a lot of these as well at our USC Pituitary Center. These are almost always benign tumors. The problem with pituitary tumors is that they can cause vision loss, or they can cause problems with hormones. If sometimes they will secrete and make too much of a hormone. Other times they will affect the normal pituitary gland and hormone function and cause too low of hormone levels, where patients will actually have to take hormone replacement. Surgery for pituitary tumors is almost always through the nose. Sometimes we have to do open craniotomies for the more complex or larger tumors. And rarely will we use radiation, only for the most complex ones that tend to grow back will we use radiosurgery. Fortunately, there are some good medications for a variety of pituitary tumors as well. So looking at pituitary tumors, there are many ways to categorize them. We look at their size. So anything over 1 centimeter is called a macroadenoma, and often they can be smaller, called a microadenoma, which are very, very tiny tumors that can make hormones where we still need to remove them surgically. We also group them by hormone function, and the ones that secrete hormones can cause a variety of diseases, which I'll go over with you, that can really affect patients' quality of life and survival time. We also look at them with different stains for hormones once the pathologists study them. We look at invasion patterns, and we used to categorize them as benign, atypical, or cancerous, which they fortunately rarely are. But what we're learning now with most brain tumors and skull-based tumors is that we look at their genetics. And when we can study the genetics of a tumor, which for instance, for pituitary tumors, we have an NIH research grant to study. We're one of very few centers in the world that are looking at the genomics of pituitary tumors with this type of structure. And we're looking at what genes may allow us to group these tumors together, or how we can discover new drugs for treating them. So when we look at all pituitary tumors, most of the ones we treat don't make any hormones, but some of them will secrete different hormones such as prolactin or ACTH or growth hormone. These are the most common hormones that these pituitary tumors can make. The ones that make prolactin are usually the most successfully treated with medications. These are called prolactinomas. And these often present in women, and when they do, they can cause usually issues with menstrual periods, or can cause milky secretion from the breasts. And these tumors can mimic pregnancy in women. Fortunately, we can treat them with medications, and about 90% are successfully treated with medications. Rarely will we have to treat a prolactinoma using surgery. That comes up a couple times a year in a busy practice such as the one we have here, but there are some that don't respond to medications that will still need surgery. So the role of surgery for most pituitary tumors, not the prolactin ones, is established. There are many, many studies and guidelines, some of which we have contributed to, that have shown that surgery can be curative for pituitary tumors. Rarely, as I mentioned, do we rely on radiation for treating these. Sometimes we do. So what are our goals in patients with pituitary tumors? Well, many of these patients will have vision problems that we will try to improve. We'll try to improve the hormone function. When they're secreting too much of a hormone, we'll try to normalize that. We try to remove as much tumor as is safe. And then if it's not completely removable, try to create a target for future radiosurgery to treat, and then to get tissue to actually study with genetics. So again, here are the subtypes of pituitary tumors. One of the most aggressive ones can cause a disease called Cushing's disease. And this is a type of tumor that's usually very, very tiny. A couple millimeters is enough to create a severe disease. These tumors secrete a hormone called ACTH that ultimately results in too much cortisol secretion. And sometimes the tumors are so small, we can't see them on a normal MRI, which I will talk about with you. The good news is if we get the whole tumor out, we can cure these patients, which is obviously the goal. Now, Cushing's disease can be a really bad disease. If it's not treated appropriately or we can't normalize the hormones, then patients can die from this disease. It can cause a variety of heart and kidney and lung issues. This was the first patient described by Dr. Cushing with Cushing's disease, and you can see how it affects the whole body because of too much cortisol, which is a stress hormone that can cause all of these different changes. Here's an example of twin boys, and the twin on the right developed Cushing's disease. The twin on the left did not. These are identical twins. You can see how different they look, even though they're still very young. So Cushing's disease can affect puberty and development and a variety of other hormonal issues, as I mentioned. They can often be very tiny tumors, only a couple millimeters in diameter. When we can't see them on a normal MRI, we are very lucky here at USC because we're one of few centers in the world that have a more powerful MRI called a 7 Tesla MRI. The 7 Tesla refers to the magnet strength of an MRI, and most MRIs are 1.5 or 3 Tesla. For the past couple of years, we've had this new 7 Tesla MRI to study a variety of brain tumors. And for Cushing's disease, where these tumors are very, very tiny, we've been able to note a benefit in using the 7 Tesla MRI to identify these tumors and help guide the surgical approach and achieve cures. So this is an example, again, of a video. Again, if you don't like watching these videos, this will be about 30 seconds of removal of a very tiny tumor located within the pituitary gland via a surgery through the nose. So this is the entire pituitary gland you're seeing here. And the tumor, based on our 7 Tesla MRI, is located on the left side of the gland, which is over here, even though it looks like the right side on the screen. And we're working our way around this tumor to completely remove it. Here's the tumor as this yellowish structure here. And we were able to get a cure for this young woman. She was having difficulty getting pregnant and a variety of issues from the hormones. And I'm happy to say she now has a new baby at home and is doing very well and is in complete remission from this disease. Another pituitary tumor subtype with hormonal secretion can make growth hormone, and growth hormone can make you grow. If you're young enough, it can cause you to be a real giant, which is an example of this patient here. If you're young enough and develop these tumors, it will cause you to grow excessively. And so this was a famous NBA basketball player that had a growth hormone tumor and true gigantism. This tumor, however, can also reduce survival in patients and affects the heart and lungs again, and can cause a variety of cancers to grow. So it's a terrible disease for patients who have it if not treated successfully. Here's our group at USC seeing a consultation of currently the tallest man in the world from Turkey. He provided permission to use this photo as well. And he had, again, a growth hormone secreting pituitary tumor. Fortunately, these can be cured if treated properly by a combination of surgery. Occasionally, they will need medications to keep them in remission, and less commonly will need a form of radiation. So just another example of what these tumors can look like. And we can use cameras to look around corners in areas where we couldn't do this years ago, to allow us to remove more tumor than was possible even 10 or 20 years ago. Another example of a large tumor in a patient with acromegaly and a pituitary tumor located along the skull base, where we were able to remove it and get this young man into remission from a hormone standpoint. The most common type of pituitary tumor does not make any hormones, and these are called non-functional pituitary tumors. And we usually see these in patients because they get large enough to cause vision problems and hormone problems, as well as headaches. And because these are the most common pituitary tumors, we treat a lot of these. We published a series of treatment of pituitary tumors from our center in over 1,150 consecutive cases. What I'd like to relay as a message, as a take-home message here, is that the complication rate of these operations when done in high volume centers should be relatively low. And I'm happy to say, here's another example of a study we published just a few weeks ago with over 400 endoscopic cases of pituitary tumors. Our death rate was 0%, and we had one case of a carotid artery injury that we were able to successfully treat, and very low rates of low pituitary function after the operation. Most of these patients stay in the hospital for 2 days or even 1 day. We're able to remove the whole tumor in right around 60% of cases and get over 80% of patients into normal hormone territory. So these are just some examples of non-functioning pituitary tumors before and after surgery, and how we're able to preserve the normal pituitary gland and hormone function in most of these cases. A very small subset of these tumors will be very, very large, to the extent that we will have to do something called an extended approach, which is where we remove more bone outside of just the pituitary gland to address removing the entire tumor safely. And these can, when you hear the word extended approach, that's usually a more involved operation that requires more technical nuances. So keep that word in mind as well. Another type of tumor we see along the skull base is called a craniopharyngioma. And this is a less common tumor, but can be a more aggressive subtype of tumor. We see these in kids as well as adults. They can also cause vision loss and headaches and a variety of pituitary hormone issues. When they present in kids, they often can cause hormone issues, obesity, or hydrocephalus, which is accumulation of fluid in the brain and pressure. But in older patients can cause confusion and memory loss, as well as fatigue and lethargy. These tumors tend to arise just above the pituitary gland, near where the optic nerves are, which is why they are associated with vision loss. So these tumors can be more aggressive. They're often solid and cystic tumors. They can be combined solid or cystic tumors, as you can see from some of these MRIs. And these are tumors that people believe are related to benign cysts in the pituitary gland and are thought to be developmental tumors that occur as you're developing as a fetus or a baby. And as you grow into an adult or an adolescent, they can grow and cause problems. So it's kind of a spectrum of a disease going from benign cysts of the pituitary all the way up to aggressive craniopharyngiomas. And surgery is really the best approach for these. So surgeons will go back and forth about considering a craniotomy versus an endonasal approach for these. But most craniopharyngiomas can be treated with endoscopic endonasal techniques. Here are just some examples of some larger craniopharyngiomas. Here's another example of one. And what I just want to share with you here is why an operation through the nose is perfect for treating this tumor. It's usually the shape of the tumor and where it's located along the skull base that lends itself well to an endonasal operation through the nose. And that's how we do most of these. Even the larger complex ones can be treated successfully with endonasal surgery in many cases. The open craniotomies for these are usually when they grow back and will require a reoperation that we will consider that. Now, what's very interesting about craniopharyngiomas, especially this subtype called a papillary craniopharyngioma, is within the last 5 or 6 years, we have discovered genetic alterations in these tumors that we can treat with medications. And this is a radical departure from how we've treated skull-based tumors in the past. This is the future of treating brain and skull-based tumors. And I think this is one of the most important discoveries in skull-based tumors in the last 20 or 30 years. So we now have medications available for this subtype, but in the future, we will have them available for many subtypes of meningiomas, pituitary tumors, craniopharyngiomas, etc. The next tumor type I'm going to touch on is a chordoma. And that's the one I mentioned at the very beginning of the lecture in the young man who had this tumor located along the skull base. Chordomas tend to be more on the malignant side. Even though they rarely metastasize, although they can metastasize out of the brain, they tend to grow back locally and be very invasive tumors. They can also arise in the spine, and actually at the very base of the spine called the sacrum, you can also get a chordoma. Excuse me for just one moment. When they arise in this skull base area called the clivus, the most common thing they present with is double vision, and we can fortunately treat these through the nose as well. So here's an example of a chordoma. They don't arise within the brain, they arise from the bone itself, which is why an approach not going through the brain is favorable. An endonasal approach is really the preferred way to treat many chordomas and their cousins called chondrosarcomas. This is just a depiction of that area of the skull base called the clivus. And again, the reason I want to show you this is to show you the intricacy of all the cranial nerves and vessels in this area. So there are numerous cranial nerves on your left and right side that subserve function, including vision and movement of the eyes and facial function and hearing and balance and swallowing function that can be compromised by the tumors or by the operations to treat these tumors. So we used to treat these with open craniotomies for the most part, but we've now started trying to preferentially treat them with endoscopic approaches. And when we're able to remove most of the tumor, those patients have better outcomes. So in chordomas, the two factors that are most associated with better survival rates and outcomes are an ability to remove the whole tumor and a follow-up with some type of radiation. And those two things in combination have shown the best outcomes moving forward in patients. So again, the first operation is the most important to be able to remove as much of the tumor as is safely possible. And then following that up with radiation in most cases is usually the best strategy for these patients. And survival can vary based on how much of the tumor is removed and what type of radiation or where the tumor is located. So I'm going to change gears here again to talk about one more very common type of tumor, which are called schwannomas. Now, schwannomas arise from the nerves themselves and the nerve sheaths. And in the skull base area, they usually arise from the cranial nerves, of which there are 12, and so they are paired, so 24 total cranial nerves, and they tend to arise from the eighth nerve, which is called the vestibular nerve, and you will hear the term vestibular schwannoma or acoustic neuroma to describe that. That's what you're seeing here in this patient here. So these tend to be behind the ear. And the second most common type are called trigeminal schwannomas, which arise from the fifth cranial nerve. And that can affect facial function and sensation or cause pain in the face. The treatment for these can also vary and vary widely. Anything from observation, if they're discovered incidentally, or they're smaller or in older patients. And if they require treatment, they can be treated with radiosurgery or open surgical resection, both of which can be very, very successful. So surgeons will go back and forth or even debate what the best course of treatment for patients with a variety of skull-based tumors, but schwannomas in particular are. And so there's a lot of very critical decision-making that goes into the treatment for these tumors and what the best approach is for them. And there's very good data to support many of these. So often patient preference, when multiple options are available, and really weighing the risks and benefits of each of these and having a conversation with your neurosurgeon or your radiation provider or oncologist or the whole multidisciplinary tumor board team is the best way to go about making that decision about what's right for you if you're faced with a skull-based tumor. This patient was a great candidate for radiosurgery. This can be treated in a single day as an outpatient with gamma knife radiosurgery. We were able to look at our rates following up gamma knife radiosurgery for acoustic neuromas. The other name for that is a vestibular schwannoma. We were able to show a tumor control rate of 98% at 5 years. So that means that these tumors did not grow in 5 years in 98% of patients. So you may ask, does it make the tumor disappear? The answer is usually not. The tumor can sometimes shrink a little bit in a minority of cases, but almost never goes away for this type of tumor. We consider a success if the tumor doesn't grow, and we call that tumor control. If you go out to 10 years, this rate can drop down to the mid 80th percentile or low 90th percentile, but it's still very favorable. What's nice about radiosurgery is the safety profile and not needing to undergo a major operation. So a single day of treatment or a few fractions or days of treatment can often be safer for patients than a major operative resection. So the tendency is for older patients to sometimes be referred for radiosurgery and younger patients to be referred for open resection. That's not a hard, fast rule, but it can be sometimes a general guideline. So I'm going to very briefly talk about malignant or cancerous tumors of the skull base. And this is an example called an olfactory neuroblastoma. The other name for that is an esthesio-neuroblastoma. And this arises from the nerves that subserve the sense of smell or olfaction, which is located right behind your nose, under your forehead, in this area here. And again, we used to have to treat these with open craniotomies and removal of the forehead, but fortunately, many of these can be treated through the nose as well. And you can see how going through the nose enables us to really get to this whole tumor, and you see the outcome here. These patients with malignant tumors, whether they're olfactory neuroblastomas or sinus malignancies, such as squamous cell carcinomas, or even metastases, even though they may have surgery, may require radiation and chemotherapy afterwards. So in the last 5 to 10 minutes here, I'm just going to talk about some surgical nuances. I've tried to so far provide an overview of the most common skull-based tumors that we face as doctors. And now I'm going to talk a little about different surgical and non-surgical strategies, irrespective of some of these tumor types. So this is a little technical, but again, I want to highlight the word approach. And there are many ways to get to a given tumor, many of which may be the right way. This depends on what your surgeon may be comfortable with. Some of these may be larger open craniotomies. All the way on the other end of the spectrum is a minimally invasive or endoscopic, perhaps endonasal operation. The nice thing is, in this era of surgery and technology, and with many of the newer tools that we have and evolving tools, one thing we haven't fully incorporated is robotics into neurosurgery, which we will in the next decade or so, is that we can access almost the entire skull base and brain with minimally invasive approaches for selected tumors. So using very small openings, going through natural corridors, as you can see here. So we call this a 360-degree approach to the skull base. Again, here's a surgical video. The reason I show this one is on the left from 1962 is the first video I know of the use of an endoscope for operating through the nose to get to a pituitary tumor. So we're going to compare this to where we are just a couple years ago and how we've evolved in terms of the optics and technology to successfully treat patients. And we're seeing more and more rapid evolution of these techniques. So a huge change here, but getting better and better all the time. And out of our shop here at USC, over 40 years ago, we discussed one of the benefits of the endoscope, which is an angle of the lens to look around corners. So another benefit is to see into areas we could not see before. And going through the nose, as I kind of shared with you, we could access the whole midline skull base, going from the forehead down to the upper cervical spine. So this whole area is fair game now, whereas we could not reach a lot of these areas via these approaches even 10 or 20 years ago. So again, some of the complex skull-based tumors we can treat now with what's called these extended endonasal endoscopic approaches. Volume is a very important consideration for treating these, and it has been established many, many times that the higher the volume of a given center or surgeon, that is associated with better outcomes in brain tumor and skull-based surgery. That's because those centers may see rarer tumors or more complicated cases that tend to recur. And obviously, the more you do something as a team, the better equipped you are for dealing with not only the easier cases, but especially the harder cases. So I'm proud to say that here at USC over the last decade, we built out a very experienced service line for minimally invasive skull base and brain tumor surgery, and have done well over 1,000 of these operations. And that just comprises a small subset of brain tumor surgeries that we do, many of which are traditional craniotomies. So just a kind of breakdown of what some of these are, and so you can understand the categorization better, and a variety of ways which we use minimally invasive surgery and the endoscope to get to these areas. So I've shared many of these with you. An eyebrow surgery is an example of that, and what that tends to look like. And then some examples where we will select using these approaches. This was a patient who had surgery through the nose, and the tumor was not completely removed. So rather than go back in through the nose where there's a lot of scar tissue, or it's a more challenging surgery, or there's a reason we couldn't successfully remove it the first time, we'll decide on a secondary approach to really enable us to get the whole tumor out. And that's what happened with this patient. So I'm going to close with talking about radiosurgery and radiation, which is absolutely critical in our armamentarium of treating skull-based tumors and brain tumors. There are various forms of radiation and radiosurgery. But stereotactic radiosurgery means that we use very precise coordinates and usually MRI imaging to target these tumors. We treat a variety of tumors as well as non-tumorous conditions with radiosurgery. It's what I love about this is it's a team approach. This is our phenomenal team here at USC. This is Dr. Eric Chang, who I work with very closely. He's the chairman of radiation oncology. This is the Gamma Knife machine. We also have something called a TrueBeam machine here. So we go back and forth using these for different types of tumors, and we're getting a brand new Gamma Knife icon in 2021. So I'm very happy to say that we have an extensive experience going back many decades and successfully treating patients with this. This is how it works. The Gamma Knife can target skull-based tumors or any type of stereotactic radiosurgery using beams from hundreds of different angles that all can target the tumor. Just an example video here. I'm going to kind of go through this a little more quickly here. But this is kind of like an MRI machine that the patient will go into. And then this is the actual radiation source that will target a tumor from almost 200 different angles to minimize radiation to the surrounding brain, but really maximize radiation to the tumor. So just some examples of when we may use this. Here's a patient with a more aggressive invasive pituitary tumor that I operated on. I could not get the whole tumor out because it was attached to the carotid artery. So safety first and do no harm to the patient. It started growing back very slowly over a couple years. And rather than re-operate on this patient, this is what the Gamma Knife treatment plan looks like. This is, you could see how tight this targeting is around the tumor and sparing radiation to the surrounding areas. Really good data to suggest doing this right after surgery to prevent regrowth, especially in younger patients. And again, sometimes in patients with Cushing's disease or acromegaly, we'll use this as a backup measure. Just another example of what this plan may look like to treat these tumors. So in conclusion, optimized care for skull-based tumors is best provided by a multidisciplinary team working as a unit to treat these diseases together. Whether it's medical management, surgery, radiation, and clinical trials, you want a variety of providers that work as a team with a weekly tumor board. This is our team at our Brain and Skull-Based Tumor Center. It's a pleasure to work with these providers on a daily basis. These tumors are inherently challenging and, as I mentioned, optimally treated by experienced teams with high volumes at what we call so-called centers of excellence. Surgery can be curative for benign tumors when they're completely removed. But when they can't be completely removed, either due to invasiveness or to location and surrounding arteries and nerves, the goal is to get maximal safe tumor resection and then use what we call multimodal strategies, whether that includes radiation or medications or even observation to keep a close eye on patients or prevent the tumor from growing back. When available, minimally invasive, endoscopic, and radiosurgery options are wonderful for patients with complex skull-based tumors. So I'd like to thank all of our attendees, all of my colleagues, and then the ABTA for allowing a platform to share some of our thoughts and experience, as well as the USC Brain Tumor Center. This is just some disclaimer slide, and then I'm gonna leave it here and hand it over to my colleague Ambreen, who is going to help us field some questions from you all in the audience. Thanks again, and Ambreen, all yours.
Thank you so much, Dr. Zada. So we do have some time for questions. As a reminder, if you do have a question that you'd like to ask, please type and submit it using the Q&A button at the bottom of your control panel, and we'll answer as many questions as we have time for. So one of the first questions that we have here, Dr. Zada, is asking, you had mentioned the importance of that first operation, that it can really offer better long-term outcomes, and something to look for, you had mentioned, was high volume centers and centers of excellence. Can you provide some advice for patients who are trying to find the right treatment center? What are other considerations that they should keep in mind? How can they get the information about volume? And how can they determine where is the best place for their treatment?
Those are really that's a great question. There are many resources available. The most important thing is that you trust your doctor and your team. The relationship between a patient and a doctor, especially a surgeon, is really critical. And so you have to trust and be comfortable with your team. Resources such as the ABTA or a variety of other brain tumor and skull-based tumor, or even disease-specific organizations. The CHORDOMA Foundation is another example. There are many meningioma and pituitary foundations and associations that can help guide you to a high-volume center. The ABTA knows a lot about this. You're always welcome to email me or other experienced skull-based surgeons or providers to help get you to the right place. But ultimately, somewhere that does provide this team approach is best suited for these patients.
Thank you so much for that advice. And if you are interested in calling the ABTA's care line to learn about options and treatment centers, our care line number is there at the bottom of the slide, 1-800-886-2282, and we'd be happy to help. Another question we have here, Dr. Zada, is asking about recurrences. What are the factors that you consider when determining the best form of treatment for someone who's had a skull-based tumor that is now recurred?
Yeah, that's a really good question as well. We look at many things here. The first thing is what type of tumor it is and what condition the patient's in, what their neurological function or deficits may be. And then, it really is something we look at with a tumor board, and we ask ourselves, can we remove everything or successfully treat this with another operation? Is that feasible? Can the patient tolerate it? Do they want that even? If not, can we treat this with some form of radiosurgery or with a medication? Obviously, that's preferable when possible. But we really look at all of those, or again, a multimodal approach. But there are so many factors that come into play that we consider. Age is another example, pathology, in making that determination. I tend to reoperate on a lot of tumors here because oftentimes patients will have surgery out in the community or somewhere else, and then present to us with a recurrent tumor, and that's our job to try to treat that successfully. So many considerations, great question, team approach.
Great, thank you. Now you mentioned that a lot of times you're able to remove the tumor and it can help to reduce some of the symptoms that patients are having, such as vision loss. For patients who've had tumor removal, do you see that reduction in their symptoms and side effects long-term? Do they tend to still continue to have issues? Will they need rehabilitation and follow-up care after surgery?
Another great question about recovery and long-term versus permanent issues. Every patient's different when it comes to this. Every tumor is different. Some have no problems and feel much better after surgery, and others will suffer from temporary or even permanent deficits. These can often be cranial nerve deficits that can arise. Fortunately, many of these can be transient, but some patients do experience permanent deficits after surgery. The time course for recovery is usually a couple months. Up to a year is when we say a patient usually has a new baseline that we consider. But really, every case is different and every tumor is different when it comes to this.
Thank you for that insight. You talked a lot about different types of radiation that can be effective for skull-based tumors. Is proton radiation an option for any of the types of tumors that can occur near the skull base?
Definitely. Proton beam therapy is not widely available. It's located in specialty sites, but becoming more common. It is a great option for many of the tumors I've discussed today. Classically, chordomas are the ones with the most data available for proton beam therapy. But if you're curious about this, there are some resources and data available There are many questions here from patients that I'll try to type answers to. Ambreen, is that okay if we don't get to them about questions from some of our attendees? So I will try to respond to you. You can always email me as well. And I'll be happy to share my email address in the chat box as well.
Thank you. And yes, please feel free to type and answer any of the questions that we don't have a chance to get to. So I'm going to take another question here. And this one is asking about the potential of spreading. Do tumors that occur near the skull base, do you see them proliferating or entering other areas of the brain as well? Or does it kind of depend on the type of tumor?
It depends very much on the type of tumor. The malignant ones will definitely do that, but what's challenging with skull-based tumors is they can be benign but still invasive, and that invasiveness can grow into bone, around nerves, around arteries, or even into the brain itself, and that's when they become more challenging. So, a variety of skull-based tumors can do this. Actually, all of them can do that. And so, that invasive quality is very, very critical when you're talking about skull-based tumors. But when they get larger and more invasive, then they can grow into the brain and be more challenging.
Okay, thank you. Another question we have is asking of the tumors that you've talked about during this discussion, are any of them more or less likely to cause seizures? And what about them might be causing that symptom or side effect?
Another very good question. Yes, some of them are more likely to cause seizures. They tend to be the tumors that invade the brain itself, as you just mentioned, Ambreen. Once they can grow through certain coverings of the brain, especially one called the arachnoid, and push on the brain and cause edema, especially in certain areas, which are the temporal lobes, which are the most likely to cause seizures, then those patients can have seizures arise from those tumors. Other locations are much less likely. Anything in the cerebellum or often pituitary tumors will rarely cause seizures. So it's very location dependent.
Thank you. And I think we may have time for one more question live. This question is asking about having an endoscopic surgery versus a craniotomy. Can you briefly touch on why one would be recommended over the other?
Yeah, that's a great question. I could talk about for an hour just on its own about the benefits and drawbacks. It depends on so many things. The first is the size of the tumor and what it's adjacent to, arteries, nerves, and whether there's a good endoscopic or endonasal way to get to it. The second is surgeon experience. That's why it's so important to go to a treating physician who, in many cases, has experience with both. So they could decide which is better for a given patient. If a surgeon only knows how to do one of these operations, then that's all they can typically offer. But to a surgeon that knows how to do open and endoscopic approaches, they are, in my opinion, they have a better ability to make that judgment call based on the benefits and drawbacks of each. So again, why referral to a tertiary or higher volume skull-based center may be a better idea for more complex tumors is the ability to decipher and differentiate and help make those decisions for a given tumor. But in general, if a minimally invasive option is available and still offer the same ability to remove a tumor, then it's preferable because we think that healing time and recovery time and pain is better for those patients.
Great, thank you so much. That is all the time that we have for today. Thank you all for joining us. And thank you once again, Dr. Zada, for your wonderful webinar presentation.
My pleasure, thank you. And if, Ambreen, if we could just leave the chat box open, I'm gonna go through them and try to respond to people if that's okay.
Yeah, please go ahead. Thank you so much.
Thank you.
Aside from our educational webinar series, the ABTA has a variety of programs that help support patients and caregivers throughout their experience. For more information about ABTA's programs, events, and services, visit ABTA's website at abta.org, email us at info@abta.org, or call the ABTA Care Line at 1-800-886-2282.